Welcome to another episode of What Brings You In Today.
I'm Erica Bennett.
And I'm Taylor Fisher.
And we just want to start off by thanking everyone for tuning in today and to listening to all of our episodes. Be sure to follow us and like and subscribe. And of course, you can always leave a review as well.
And also, if there's any topics you would like to hear our guests talk about, you can go to our website, sgmc.org/podcast, and you can submit your topics there.
All right. Well, today we are joined by James Davis, MD, general surgeon, but also fellowship trained in endocrine surgery. So, Dr. Davis, what brings you in today?
I was hoping, I watched a few of these podcasts, and I thought it was a good strategy to kind of bring some updates to SGMC surgery as well as the practices in endocrine surgery as we go into the new year. So, yeah.
All right. Well, tell us a little bit about what made you pursue kind of your journey in your medical career and what led you to becoming a surgeon in endocrine surgery.
Yeah, so I was not the standard, I want to be a doctor kind of kid growing up. So it was more of I went to college and kind of nerded out in some of the sciences, specifically physics and chemistry, but I didn't really see a future in that. I didn't know what I was going to do with a physics degree. And I had a mentor that was married to a physician, and she encouraged me as a chemistry professor. She encouraged me to say, hey, why don't you take an MCAT? Why don't you try to go the medical route? And it was as simple as that. I had my father's best friend was a general surgeon, so I had shadowed him a little bit. I kind of liked that part. I shadowed a few more years in undergrad, and then I took the MCAT and pursued it on. And then as far as endocrine, when I left medical school, I didn't even know what endocrine surgery was. I knew I was going into general surgery. I anticipated a career doing broad-based general surgery, hernias, colons, all that. And then about my third year of general surgery training is when I recognized the need for specialty training in certain areas of the body. There were certain organ systems that you really needed to be proficient at, you need to be high volume at in order to be really good. And it makes sense, I think, to most things. If you're going to have a Whipple done, you want somebody that's doing 50 Whipples a year. You don't want somebody that's like, I did 3 last year. It's just not what you want. It's not what you want for your loved ones.
Makes sense.
So that was kind of where my thought process went with endocrine. As I said, I want to be really proficient and do a lot of thyroids, a lot of parathyroids, a lot of adrenal surgery. And I recognized a need in South Georgia. So when it came time to look for a job, I recognized there really wasn't a lot of high volume surgeons below Atlanta doing this kind of stuff. And that was attractive to me for a job. And SGMC allowed me to continue to do general surgery practices, so as far as hernias, colons, everything like that, and practice with one of my best friends, and also bring endocrine surgery to South Georgia. So.
Very cool. So you mentioned Whipple, and I don't know what that is, but you don't have to tell me what that is. But we do need to know what thyroid, endocrine. Okay, thyroid. You said parathyroid. There's different. What is that, and what does it mean to the person's health?
Yeah, so probably the number 1 and number 2 complaints that patients are wishing are related to that thyroid is fatigue and hair loss.
Weight loss. I thought weight loss
weight
would
loss
be
is right there too,
okay.
Probably number 3. But a lot of people will come in my office and they're going to mention, hoping, kind of crossing their fingers that they're losing their hair and it's related to the thyroid, or something along their energy levels is going to be related to the thyroid. And I am too, because I can fix that.
Yeah.
It's awkward when I say your thyroid looks like it's functioning great. I have no quick fix for your hair loss. All right, I don't have a fix for my hair loss.
Right.
So these are things that you see on a day-to-day basis. And then the weight is definitely up there as a common complaint. But really, what you're looking for with the thyroid, as far as surgical needs, is the gland over functioning? Is it got a nodule in it that's causing compression of other areas in the neck? Or is the nodule have suspicious characteristics? So thyroid cancers, Graves' disease, toxic multinodular goiters, and then big, large goiters that we see down here that are kind of substernal, these really, really big goiters that we end up sometimes having to open the chest just to get it out. So these are typical pathologies that I deal with endocrine surgery.
So a goiter is literally just like a big like knot.
I tell people, and it is a term that's thrown around very loosely. So a lot of people say, I've got a goiter, and I look at the dimensions of their thyroid, and I say, no, your thyroid's just slightly enlarged, not bad. But a true goiter is enlargement of that thyroid gland. And you've got multiple nodules most of the time that are kind of compressing other things in your neck that lead to that development of symptoms. And the typical symptoms we look for are trouble swallowing, maybe some voice changes when they lay down at night, a fullness on their neck, they turn their head a certain way, they feel that fullness or weight kind of pushing. It's not so much pain in the neck. That's kind of a atypical finding when it's truly causing pain, but usually that swallowing is the first couple things they develop. Or they look in the mirror, they're brushing their teeth, and they go, what the heck is that? And they see something kind of popping up in their neck when they swallow.
So what exactly is the thyroid's purpose in the body?
So it serves all kinds of systems across your body. It doesn't get a lot of street cred like other things because we have a medicine to take its place, which is Synthroid or levothyroxine. And the most common reason you end up on that medicine is because as we age, sometimes our thyroid just burns out. Okay, and it's something that your primary care doctor is going to pick up on their routine labs. They're checking on you once a year. That thyroid function test starts to show that it's burning out, and then they replace it with Synthroid or levothyroxine, and that typically does the trick. The second most common reason you end up on that medication is and that's when we take the thyroid out for one of those reasons we mentioned earlier with the pathology. But it serves all kinds of purposes across your body as far as your sleep-wake cycle, your energy throughout the day, your weight, your fluctuation, even your blood pressure. So it helps lots of other systems work really, really well and fine-tune those systems.
Well, so thyroid surgery, I know you do Da Vinci surgery, and I'd like to talk a little bit about robotic surgery, but in regards to the thyroid, is that like a major procedure, or what type of risk level are those?
So I define a major procedure as any procedure done on my body. That is major, okay? and I treat the patients the same way. So it's always a situation where you want to be there with them from the time they go off to sleep and they're intubated, because it is scary. It is nerve-wracking to them, although we're doing them multiple of these per day, To them, it's their one and only time they're having thyroid surgery. And it is a big deal. But as far as the cosmetics and all, we try to hide it in a natural skin line. My goal is a year down the road to not be able to see that scar unless I'm really squinting and really looking closely at their neck. But the neck itself, great vascular supply, not much tension on the neck. So usually you get a good cosmetic result as long as you can put the tissue planes back together decently.
Yeah. Well, I do like the comment you made about specializing in something. I mean, that kind of resonated with me. I didn't really think about that until you said it, especially when it comes to surgeries within your body, having somebody that does a multitude of the same procedure over and over and over so that you really get that skill set. So that's pretty cool. And I'm sure we can talk about that with Da Vinci. So robotic surgery, that's the biggest trend now. I mean, it's been around for a while. But tell us about the benefits, kind of what surgeries you're able to do with the Da Vinci robot, and kind of where you see that trending.
Yeah, so we've got the latest developments in the robot right here at South Georgia Medical Center. We've got a Da Vinci Xi robot. We're in talks and probably going to be rumored to be getting another one within the next year. So our procedures and the case logs that we're doing, that production continues to ramp up for robotics. So, and that's just what patients are desiring. They want the minimally invasive approach. They want you to fix their hernia, but they want you to do it through small incisions. They don't want a big cut across their abdomen. They want, and again, I want the same thing. It's a lot of pride to be able to know that they can put a bathing suit on again, and they don't know I was there, So it's a kind of a stealthy move type procedure, and that's attractive as far as their recovery process, as far as the cosmesis, everything. And so as long as you can offer them the same type of surgery as the open, and that's what the Da Vinci robot allows. So it's laparoscopic surgery with better visualization and wristed instruments. So it's more natural motion versus the traditional laparoscopic surgery. And it really has, I've kind of watched it from when it first started, and watching some of the guys that were training me have to have a learning curve and come on board with Da Vinci. And general surgery was one of the places that really caught on later. It wasn't grabbing it up front. It was really holding back and kind of Heismaning the approach. It eventually caught up with it and said, yeah, I think there's a place in general surgery for this technology. And really where I find it advantageous is foregut cases and then down the pelvis. And then when you've got your morbidly obese patients that have these really, really small hernias, I mean, to have a patient who's pushing over 250 pounds with this really, really small hernia, but symptomatic hernia, to go and make this big cut on that individual, you're, from a cosmetic standpoint, not going to make a new friend. You're going to increase your chances of a surgical site infection. And of course, the postoperative pain will be worse. So those are really attractive options for that robot. And that's what I use it for my practice. And so when I came to town, there wasn't anybody doing high volume foregut surgery here. And so that's where I just kind of waved my hand and said, I'm willing to do hiatal hernias and Nissens and those type procedures. And sure enough, it kind of pushed my way. So I see my office is a lot of kind of colons and foregut cases and hernias, and it's a good breadth of general surgery. So my day is never boring. And then, of course, the endocrine practice keeps coming too. So, but I do think the robot has a place in general surgery. I think we've swung that pendulum all the way to where I kind of, if anything, harp that maybe we use it too much sometimes. There are cases that you probably don't need that technology for. And I think right now, especially among service lines, adding urology, OBGYN that uses it, cardiothoracic that uses, as well as general surgery, we really have to kind of play nice in the sandbox and say, these are appropriate cases for that robot. These are cases I can get done traditionally in a laparoscopic fashion or better served open. And I think that judgment, or being able to have that toolbox where I can use all three options on a patient's certainly attractive. So,
are there any disease specific surgeries or related from certain diseases that are prevalent in our area that you're seeing?
I see a lot of big hiatal hernias,
And what's the hernia?
So there are hernias all over your body. Hernia just means hole. That's all it means, is a hole. And so the kind of classic hernias you hear about are umbilical hernias, so that belly button protrusion, or a groin hernia, so that inguinal approach. And that's the two most common. And I treat those as well as my partners. But then the hiatal hernia is that natural defect from your esophagus as it turns into your stomach below the diaphragm, that opening right there that allows the esophagus to enter into the stomach. As it widens up, the stomach likes to slide up into the chest. And that's classified as a diaphragmatic hernia or a hiatal hernia or a paraesophageal hernia, the terms that get tossed around with that. And so I end up fixing a lot of those, and the robot is definitely the way to go. I will never do one traditionally laparoscopic rigid. It's just the flexibility of those wristed instruments, the visualization, looking up, being able to see not only the abdomen, but looking up into the chest cavity. And you're doing it all through 8mm little cuts, which is certainly better than the old school open approach.
Yeah. Those things are so cool. We got to kind of test them when they were here in the lobby, and I just, I'm not a surgeon, but I was trying to get the hang of it just to pick up these rings, and I just can't imagine.
It's addicting,
doing
almost
that.
a little game.
It was like a game, yeah.
Yeah, so I mean, it's the same thing. The visualization is certainly impressive. That you get to sit down and, even the techs that are helping or assisting at the bedside on the individual. When I sit down at the robot, there are things that they're seeing on their 2D monitor that look very different when I'm looking through that console of that robot. And there are things I can almost look around the corner and they go, how does he know to see that? Because they've got a 2D lens, whereas I'm looking through there and it really is truly 3D approach that I'm getting to see up into that hiatus. So
yeah, when we looked at it, the representative, I guess, from Da Vinci had a penny in there, and she said, or maybe it was $1. I think it was a penny, though.
It was $1, and they hit the nose on George Washington with the pen.
Yeah.
Well, I don't know about that, but the one I did, you could zoom in and you could actually see the words on something that you would have never seen. I think it was the penny, and it was something
Maybe
written
I'm thinking
on
of something from a TV show.
But anyway, it was just, I would have never even been able to see that with the naked eye, so that's crazy.
I think that was on Grey's Anatomy, actually.
Okay, well.
Maybe. I don't know.
For those so a lot of people are scared of surgery, right? I mean, it's you're going under most of the time, and so you're really patients are putting their trust in the surgery team and their surgeon. So what do you Tell patients, how do you?
I try to do my homework. Most of the time, if you're seeing me in the clinic, I've done my homework on you the night before. So when I'm popping my head in to meet you for the first time, I kind of know what the imaging looks like. I know the story from the physician. So most of my approach is essentially sitting down, just like we're doing right now, and kind of hearing the patient's perspective of it, because that's what I don't have yet. That's the gap I don't have for my documentation, is what is their side of the story? Why are you here? And that's a common question of what I'll start with, and it kind of throws them back like, don't you already know?
Yeah.
Well, yeah, I know what the doctor's telling you here for, but you tell me your side of the story. And so that gets me that subjectiveness so I can truly understand, are their symptoms going to match up with the disease process? Because if they're not, I can do the best hernia repair in the world, but if they came in, their symptoms don't truly match up with the hernia, they're going to be disappointed with that result. Yeah. And so I'll spend most of my time just kind of talking and hearing their side of the story, and then I'll spend another 5 or 10 minutes looking for snakes under rocks. You know, where's that snake? Where's the blood thinner that's going to stop me? Where's the irregular heart rate? You know, something along those lines. And then we kind of talk about the surgery for the rest of it. And we'll say, all right, this is what I think you need. I recommend this operation. And I try to use picture diagrams because I do ramble, as I do now. I will ramble in that clinic appointment with the patient. And so I'll use a lot of picture diagrams so it kind of makes sense to that individual. This is the organ we're going after. This is the approach we're going to use. If you don't like that, we have other options, and I'll bring those into the conversation. And then after that part, because remember, most of the days the patient is also coming in having done some homework. And Dr. Google is not their friend. Okay. And so Dr. Google has already given them some information. Yeah. And so the last part of it is really after I've gone through what I think we ought to do, whether it's surgery or hold off, it's what questions do you have based on your homework from Dr. Google? And some of it's accurate, some of it isn't, but we try to dispel that part for the final part of it. And then any additional questions are answered. And then usually at that point, you've got the patient pretty comfortable. You've got them understanding their process, what are true realistic expectations. And if they're comfortable, I let them meet my scheduler that same day. So we try to be as efficient. If I need labs, we draw labs that same day. So we get them through that process as quickly as possible. But also, I think most of my patients will leave that office having learned something that day, feeling comfortable with it. And sometimes you end that conversation with just saying, hey, I've given you some information. I've given you some stuff to think about. Let me give you a buzz tomorrow. Yeah. You head out today, you talk to family and stuff like that. Because that's one thing I love about this place is you're going to get some different opinions, you know, and people leave that office, they know Dr. So-and-so and they want to talk to them, or, hey, my aunt's a nurse in this hospital. And I was like, that's great. Go talk to them. I'll give you a buzz tomorrow. Let's finalize the plan that way. So.
I think that's great. We talk about the Dr. Google a lot because we know that now more than ever, people have a choice of they even do this with their choice of their hospital. They're Googling, they're looking at reviews, or they're talking. I'm in the marketing field, but word of mouth is always still going to always be your number one referral tool. Yes. So do you have any particular story, a patient story that you found like particularly rewarding or interesting? That, obviously not sharing patient information, but
yeah. So the couple come to mind. So in surgery, one of the reasons a lot of people go into surgery is this instant gratification. We get to fix a problem right there on the spot. So if it's a gallbladder attack, they come in with pain in that right upper quadrant. You take the gallbladder out, you're their hero right there. So it's instant gratification. You fix that problem, and so that kind of comes with the territory. But just thinking about patients that have kind of popped in my head recently was a kind of a cool, interesting zebra case, was something called a pheochromocytoma. And that's a neat tumor that involves the adrenal gland. So think with the adrenal gland, kind of adrenaline, that surge of hormone. And this was a young, athletic individual, healthy otherwise, that was showing up in the ER with kind of panic attacks, blood pressure was uncontrolled, shortness of breath, and chest pain, like truly having chest pain with this. And they found this tumor they stumbled upon it by doing a PE protocol CT. So they got a CAT scan of her chest, trying to rule out a blood clot based on her symptoms. And a CAT scan of the chest always goes just low enough to capture that adrenal gland, which sits right on top of the kidney. And so it went low enough, it caught this thing, and it was a huge tumor. It was like a 7-centimeter adrenal mass, which is large for the adrenal. And classically lit up, hypervascular, and they said, we got to at least entertain this opportunity to get this over to the endocrine surgery guy. And right away, as soon as I looked at the images, like, this is going to be a FIA. You look at her symptoms and all this, she's surging this adrenaline hormone into her system, and that's what's happening. This was a 35-year-old female. This was someone that shouldn't have uncontrolled hypertension as of yet. She was running and walking every day until this tumor took over, until it was causing fatigue. And she was like, if I try to run right now, my heart rate goes through the roof. I get excruciating headaches. I can't even exercise. So that was kind of a cool case to be able to remove that tumor and give her back life instantly, because the minute you clamp the vein on that tumor, blood pressure returns to normal. It's really, really cool case to do. It kind of makes anesthesia panic a little bit, because the whole case they're preparing to block those hormones so that you don't see a systolic blood pressure of 250. And then the minute you clamp that vein and you get control, I do a little happy dance while I'm scrubbed in. But the blood pressure immediately drops, and you're pounding that patient right there on the table with fluids. You're trying to get them hydrated back up because you've just switched tracks. Now you've got a patient who's hypotensive, and you're dropping that blood pressure because you just cured them of all that disease. And that's a really, really cool case. And I got to see that individual for a follow-up recently, and she's doing great. And I was very, very obviously happy. She's off all blood pressure medication. She's back to exercising, and return of her normalcy. Her life is back. And that's a cool finding, back at work and all. The other case, if you got time, is I want to give a little shout out to a family doctor in town. So what we do is obviously a lot of fun, and being a doctor is great, and it's a lot of stress. There's days I come home and my wife can see it on my face that I'm wearing my work. I'm bringing it home with me. She can tell my brain's still stuck in clinic, and that comes with, I think, being a decent provider for our system. But a newer family doctor to our system caught a breast lesion recently, a breast cancer, and that was because she listened to her patient. The same thing I was talking about earlier was this patient was seeing a doctor and was telling her, I've got a mass. I found something. I need some help. Breast exam wasn't even performed by that provider. The patient, fortunately, was wise enough to say, I'm going to go check out a different provider. I'm going to get me a new family doctor. This one doesn't seem to be listening to me. That was her words. This one's not listening to me. So she met up with a new family doctor in town, Dr. Harris, who I don't even know that well yet.
We like her.
But I hear nothing but good things. But Dr. Harris got to establish care with this individual. Dr. Harris immediately listened to her, did the physical exam, found the breast cancer, and then got that patient over to our clinic for care for breast cancer. And so a little bit of, like I said, these patients, if you just sit down with them, spend some time, why are you here? What's the deal? They're going to give you that talk. They're going to tell you everything. So it's not always rocket science, and it's not always the intelligence factor for physicians. It's a little bit of just being able to absorb and listen to your patients. And I think hat off to Dr. Harris, that case popped in my brain a little bit. So.
You're almost a little bit of a counselor. In some ways, they might open up to you and tell you something they haven't told anyone else.
Some things too much. Some things, and you have to kind of stay in your space a little bit. What I love about my job is there's some things they'll tell me, not your guy for that. No, we're going to get you to that person.
It probably is such a balance, because you have some people that totally overshare or maybe really did so much homework. So then you got to know when to tune in to what, because I could see as just a person, not a physician, where you could tend to be kind of tuning out some things just for those. I mean, I'm just thinking of when I have somebody that overshares with me, I'm like, okay, you start drifting off. But really, you have to engage and make sure you're getting down to the root of everything that you can ensure that you're...
Yeah. The females do great. The males, it's like pulling teeth to get to that really nitty-gritty stuff. Like, you got to tell me this part, man. Don't hide anything. I need to know. So the best part is when the men will bring their wives to that appointment. As long as they got the CEO in the room with them, they will tell you the truth. Okay?
Yes, the wives will. They can tell all the symptoms. No, you started complaining about this actually a week earlier than that.
That's correct.
I have to do that with my dad.
Yeah. So
I have to be in the room.
It is always nice when the husbands bring their wives or significant others to those appointments, because inevitably us men, we are genetically flawed with that timeline. So it's been going on for about a week. She's like at least a year. So completely different stories.
Well, I mean, this has definitely been really insightful for me. Anything any common misconceptions people have about surgery, or anything you hear frequently that you want to dispel?
No, I think there's at least like, there's a little bit of a stereotype that goes with being a surgeon, that you're this mean, cold-hearted individual, and I don't think that's the case. I do think most of us are incredibly stereotyped correctly with hardworking. We spend a lot of time at this hospital. We spend a lot of time for our patients. And we do care. And so some days you may catch us very tired, very overworked some days, because there's several of us that we will carry this work home with us. We're always thinking about that, and that's part of it. So I think hopefully you recognize at least what we're trying to build with South Georgia Medical Center's surgery is that you're building compassionate individuals that truly are hardworking and want this place to succeed. And I think that's only going to get better. We're trying to start with our general surgery department and kind of core it out, and you're seeing specialty care. So since we've come here, we've added colorectal surgery. We're adding bariatric surgery, so expanding on different realms of vascular surgery and bringing in new CT surgeons and all this stuff. So it's just getting, each realm is getting more and more in depth, and you're adding these little specialty cases to surgery, and that's what the patients desire. That's what they're Googling. So if they need a Whipple, they need to go see that surgeon, and so they're smart enough to recognize that. And so we've just got to make sure to keep up with the times, and there is a lot of word of mouth, and I do love that part about South Georgia. One of the best things about a small town is everybody knows you. One of the worst things about a small town, everybody knows you. Okay, so that's still true in this town, but we've got to make sure that we're keeping up and treating our patients with the latest and greatest in technology, as well as the type of physician that's going to be introduced to them. So
well, I know you serve on our medical executive committee, and as well as our quality improvement committee, and probably other ones that I don't even know of, but we appreciate your service to doing that, because that's,
I like wearing these different hats on there, because I do think I want to be around for the future, and I do think I want to be part of that development process for the next several decades, so that when you do, it'd be nice to be able to see that out for several years. But bringing in bariatrics, I'm excited about that. That's a new service line that our area needed. So to bring that in, and again, looking toward the future with other subspecialties, surgical oncology, all these different fields, this is the wave, and this is what's going to be expected of this place. So,
cool.
I feel like I need to know what a Whipple is now, because you've said it like 3 times.
Pancreatic cancer. Sorry. Pancreatic cancer. It's a big pancreatic cancer operation. So, yeah.
Well, hopefully it's like one of those things you don't need to know it. You don't know
Yeah,
what it is
You
unless
don't need
you
to know
know
what it is.
somebody
I was
that
just
has
curious.
had one, or you're,
No. So it's just it's well described in the literature. Certain organs, and the pancreas being one of them, high volume surgeon. So thyroid's kind of like that. It's got a lot of literature out there. Most thyroid surgeons, if you're going to get an operation, you need to be doing at least 50 to 100 per year. And parathyroid, same thing, adrenal, certain things. So there's these numbers out there, and patients are wise enough to kind of find them, and they go find and seek out those high volume surgeons. So,
all right. Yeah. Well, we got a last question. This one's the
Last
hardest
question.
one.
oh boy.
I didn't include it in your talking point.
Oh gosh. Okay.
We just always ask everybody, since we know all of our physicians and most, nurses, people spend so much time here, what is your favorite thing to eat?
Oh, all right.
In our cafeteria or allspice?
Great question. All right, so I'm a big foodie, and I'll try anything. But we just started doing these smash burgers in the spice. They're really good. Do pepper jack, add onions to it, and get all the sides. It's fantastic. So yes, I enjoy eating up here.
Smash burger. All right.
If I'm ever going to be home late, I know the spice has me covered. So yes. Yes.
Somebody else said that too, I feel like. But yeah, I haven't tried one. I'll have to try one.
I had one the first day that they started. I was like, I'll try. I'm like you. I'll try anything. And I like to keep a variety, and so I like to know what's up.
They do it well.
Yeah.
All right.
Well, we thank you, and we know, like you said, our physicians spend a lot of time here and a lot of time with their patients, and are truly our unsung heroes, just dedicating your lives to improving the health of our community. So this part of our podcast was really to give our community a chance to hear a little bit from our physicians, to know more, get to know them, get to know them on a more intimate basis. So I just appreciate you taking time with us today.
Yes, definitely.
No, thank y'all. So I'm a big fan. I watched several podcasts, but this was cool to be part of one. So Thank you.
All right. Well, thank you all very much for tuning in, and be sure to like and subscribe. I always feel like my little son when I say that, because one time he pretended he had a YouTube channel and he always said like and subscribe. So I feel really awkward saying it. I'm just throwing that out there, but I still say it. So like and subscribe.
And also know Erica has a really big office. I just learned that. So I'm looking around, I was like, man, she's got a really spacious office. So it's great.
I had to find somewhere to shoot. We have no more room left in the hospital
No,
because we're
no.
growing so much. So
We
I
are
had to make
expanding.
my own space. But anywho, all right. Thank you for tuning in. We'll catch you next time.